1997, when the issue came before the U.S. Supreme Court, I wrote an editorial in the New England Journal of Medicine in support of that position. In it, I told the story of my father, who in 1988, suffering from terminal prostate cancer, took his pistol from his bedside table and shot himself, dying instantly. His death reinforced a view I had held since I was a medical resident, since I was in training, and first saw that dying often brings with it great suffering that simply cannot be relieved, even by the best of care. Death is not like you see in the movies. I was the lead petitioner in getting a Death with Dignity Act virtually identical to the Oregon model that was originally before you, in getting that on the Massachusetts ballot last November. And as you probably know, this referendum was very narrowly defeated after opponents outspent advocates by nearly 5-1. It lost just in the last month during this blitz of advertisements. There are two ethical principles governing medical practice that together support physician-assisted dying. First, the duty of physicians to respect the right of patients to make their own medical decisions. And second, the duty of physicians to act with compassion. Neither of these obligations alone is sufficient to justify physician-assisted dying, but together they certainly do. Thus, death with dignity laws require that the decision rest with the patient and that the purpose is to relieve suffering when cure is no longer possible. This combination, then, the patient's autonomy and the physician's compassion, in my view, overrides any objections to physician-assisted dying. I'm sure that you've already heard a great deal about how the Death with Dignity law has worked in Oregon over the past 15 years, and I won't repeat all of that, except to emphasize a few facts that I find particularly compelling. First, the law has worked pretty much exactly as intended, with very few problems. No law works absolutely perfectly, but this one seems to come about as close as possible. It's accounted for 673 deaths in 15 years, only 1 in 500 deaths in that state in the last year, less than that earlier. About 80%, fully 80% of these patients were suffering from widespread cancer, and most of the remainder had late Lou Gehrig's disease, that is ALS, or amyotrophic lateral sclerosis, or end-stage emphysema. Early concerns that the law would be used mainly by poor or otherwise vulnerable patients were simply not borne out. Most were better educated than average and well insured. Nearly all died at home, which is where most people say they wish to die. Notably, over 90% were receiving good hospice care. They had good palliative care, but did not find it sufficient, even though palliative care in Oregon is considered to be among the best in the country. Finally, about a third of patients who were prescribed medication to hasten their death didn't use it, but kept it on hand because it provided a sense of control and peace of mind. In last week's New England Journal of Medicine, dated April 11th, there's a new study from Washington State where death with dignity has been legal for 5 years, titled Implementing a Death with Dignity Program at a Comprehensive Cancer Center. The paper concerns a program at Seattle Cancer Care Alliance, the site of outpatient care for the Fred Hutchinson University of Washington Cancer Consortium. It is, to my knowledge, the first Death with Dignity program to be implemented in a major academic medical center. As in Oregon, the major reasons that the patients in this center gave for wanting to hasten their death was loss of autonomy, loss of ability to engage in pleasurable activities, and loss of dignity. Pain was much less commonly cited. About a third of patients who received medication didn't use it, as in Oregon. But they and their families were glad, this is in the article, they and their families were glad that they had the medication because of the sense of control that it provided. As in the original Oregon bill before you, physicians were not required to participate, but the authors report that, quote, a few clinicians who were initially strongly opposed to the Death with Dignity program subsequently expressed their willingness to participate as consulting or prescribing clinicians, which further supports acceptance of the program, close quotes. That's in this article last week. This is a big deal, first major cancer center, academic affiliation. So they were describing doctors who were initially resistant, reluctant, and came around as they saw the program in action. I believe this growing acceptance by initially reluctant clinicians will be the story in the coming years. Just as some 30 years ago, reluctant clinicians came to accept the right of patients to refuse life-sustaining treatment like ventilators or dialysis. That was very controversial at first. Now it's accepted. Last week's paper in the New England Journal concludes, quote, overall, our Death with Dignity program has been well accepted by patients and clinicians, close quotes. So then, what are the arguments against Death with Dignity? I'll briefly mention 4 of them here and state why I believe they're wrong, both medically and ethically. 1, first argument. Participating in hastening a patient's death is, to quote the AMA, quote, inconsistent with the physician's role as healer, close quotes. But this argument sees the physician's role too narrowly and abstractly. Yes, it's all very well to say that physicians should be healers, but suppose healing is not possible. When death is imminent and dying patients find their suffering unbearable, then the physician's role should shift from healing to relieving suffering in accord with their patient's wishes. This isn't a matter of life versus death, but about the manner of dying. And it's not primarily about doctors, it's about patients. Furthermore, doctors who object to the Death with Dignity laws on these grounds don't usually object to withdrawing life-sustaining treatment, such as a mechanical ventilator or dialysis, despite the fact that these actions lead just as surely to death, and with many fewer safeguards. 2, second argument against it. We should not permit assisted dying because no one can be certain that a patient will die within 6 months, as stipulated by the Death with Dignity laws. While it's true that life expectancy is only an estimate and therefore cannot be exact, that's not the point. The point is that the patient has a terminal illness that will cause death within a matter of months, and we can know that with virtual certainty. In Oregon, for example, nearly every patient who used the Death with Dignity law had widespread cancer, Lou Gehrig's disease, or end-stage emphysema. These are not subtle diagnoses, and the outcome is clear, if not the precise timing. So emphasizing the uncertainty of the 6-month limit is misleading. The real question is whether the patient is suffering from an incurable illness that will take his or her life fairly shortly. Moreover, if someone is suffering so much that they want assistance in dying, they would hardly be relieved to find out that they might live even longer and therefore suffer even longer. 3, patients who request assisted dying may be suffering from a treatable depression. But the diagnosis of depression is difficult under these circumstances because the symptoms overlap with those of terminal disease almost entirely. If you look at the DSM, the Bible of psychiatry, and you go through the 9 symptoms of a major depression, every one is a symptom that someone with terminal illness would have. Loss of appetite, difficulty sleeping, ruminating about death, and so forth. And dying naturally produces sadness. If you weren't a little depressed, then you really would be crazy. Moreover, there are no good studies, 0, of the effectiveness of therapy in this setting. When drug companies test their antidepressants, they don't do it on dying patients. They do it on 25-year-olds with normal life expectancies. So there's no good studies of the effectiveness of therapy in this setting. Still, the law would require physicians to refer patients for counseling if they believe a patient's judgment is impaired by a psychological condition, and that seems reasonable. So far, the limited evidence from Oregon is that depression is no more common in patients who request assisted dying than in other terminally ill patients. That's the relevant comparison, and they find no more depression in those who ask for help and die. In fact, a recent study showed that the patients who obtained the medication were less depressed and anxious than those who didn't, presumably because of the peace of mind and sense of control it engenders. 4, and last, good palliative care can relieve all suffering, so permitting assisted dying is unnecessary. Probably most dying patients, even when suffering greatly, would choose to live as long as possible. And that courage and grace should be protected and honored, and we should put every effort into treating their symptoms. And as I said, palliative care in Oregon is very good. But not all suffering can be adequately relieved. Most pain can, that's probably the easiest to relieve, but other symptoms present greater problems. Symptoms such as weakness, loss of control of bodily functions, shortness of breath, and nausea. And the drugs to treat those symptoms often produce unacceptable side effects. Even worse for many patients is the existential suffering. They know that their condition will grow worse day after day until their deaths, that their course is inexorably downhill, and they find it meaningless to soldier on. In summary, the Death with Dignity Act, the Oregon model, has been in effect in other states long enough to know that while it's not used often, it provides a peaceful end for the small number of dying patients who find their suffering unbearable. The Act does not require doctors to provide medication if they don't wish to do so. It simply provides one more choice for both physicians and patients as they face with terminal illness. I'm aware that the Vermont Senate has passed a much shorter bill with fewer safeguards. And while I'm very sympathetic with the view that a law should not have so many safeguards that they constitute an obstacle to its use, the experience in Oregon shows that the law, the original Oregon model, is not a problem in this regard. Moreover, the presence of ample safeguards makes it much more acceptable both to physicians and to the public. At base, arguments against the Death with Dignity Act seem to stem from the paternalistic notion that terminally ill patients can't be trusted to know what they want, that they need to be protected from themselves. But these patients are adults, not children, and there's no reason to treat them like children just because they're relatively helpless. Patients and no one else are the ones to say when their suffering has become intolerable. An individual physician should be able to stand with them without fear of retribution. Why should anyone, the state, the medical profession, or anyone else, presume to tell someone else how much suffering they must endure as they face death? I hope that Vermont, which is so enlightened in so many regards, will be enlightened in this regard as well. So thank you for hearing me, and I'd be happy to answer any questions.
Thank you, Dr.